Welcome to Sidactic. Today is Thursday, February 1st, 2024, and I'm your host, Dr. O'Leary. This is a podcast about psychiatry and neuroscience, and I've been doing it for about 2 years now. I'm a fourth-year psychiatry resident, which means that I'm still young in my psychiatric career. I also have no editorial board or fact checkers working for me. I'm not a journalist, but I do consider myself to be an amateur science communicator. But everything I say here is my opinion, and it shouldn't be mistaken for the opinion of, for example, the US federal government or the Department of Defense, or really any subsidiary thereof. In this episode, I'm going to explore what might just be the most discussed psychiatric disorder in history. There have been innumerable books published about borderline personality disorder by psychiatrists, psychologists, individuals that have the diagnosis or had the diagnosis, and individuals lucky enough to have been a close family member or a long-term intimate partner of someone who had that diagnosis. I am probably not going to add much of anything to this discussion, but what I will do is discuss some of the more colorful ways that this disorder has been historically characterized and contrast this with more contemporary approaches. Spoiler alert, the differences are in many ways more semantic than really substantive. And that's just a nice way to say that we really haven't made that much progress in the last 80 years. And that in and of itself is fascinating to me. Let me start with a little history of the way borderline personality was portrayed in the early 1900s. When I started this, I just entered borderline personality into PubMed and looked for some of the oldest studies I could find. So I found a few gems that I'm going to share with you today. The earliest study I found was from 1947 and was titled The Treatment of Psychopaths and Borderline Patients. The author was Dr. Melita Schmeddeberg. She describes patients who appear to be on the line between what historically was classified as neurosis and psychosis. I quote, "Such patients are unable to stand routine and regularity. They transgress every rule. They do not associate freely and often do not talk at all. They refuse to lie on the couch. They often come for analysis only under persuasion or pressure, and even when they come, their insight does not last nor carry them through difficulties. Even when they try to cooperate, they cannot sustain the effort. In their lives, something always happens, usually on the spur of the moment, entirely out of the blue. If they are poor, they are likely to become criminals. And generally, if they belong to the upper classes, they manage not to break the law too flagrantly, or at least not to get caught. Money and background provide a great latitude for abnormality so that people merely describe their behaviors as erratic. Yet in many cases, their antisocial tendencies are only too obvious, and either by omission or commission, they hurt those who become associated with them. Such patients cannot be treated by classical analysis, and since they cannot be cured by anything short of analysis, we must modify the method." Unquote. Dr. Schmeddeberg believed that all of these patients were destined for some sort of diagnosis of schizophrenia, and she probably has in her patient population many patients that we would recognize today as having borderline personality disorder, but also many patients with a prodromal or low-level psychotic disorder, or just paranoid or schizoid traits. In her article, she writes like one long stream of consciousness outlining what she uses to treat them, which are unorthodox methods. And that includes, among other things, actually talking to the patient instead of just listening to the patient, and even sharing personal details of herself with the patient, her own history, her desires and likes. And she does this, she says, in order to encourage the patient to actually show up, which is very difficult. Dr. Schmeddeberg notes that the traditional psychoanalysis that has been employed in her day is inadequate to make really any progress with her patients. And if she insists on doing it that way, that will just drive them out of treatment. Now, this article concludes with some response letters from her contemporaries. One of these is from a Dr. Fritz Wittels, who writes, Dr. Schmetterberg follows a method of her own in psychotherapy. My impression is that what she presented here was rather a piece of art than an established science. Dr. Schmetterberg is a champion in the treatment of psychopathy and juvenile delinquency. One is delighted, but one cannot duplicate it. It is not for the first time in my life that I regret this inability. The next responding psychoanalyst was Dr. Emile Goutheil. He also proposes that Dr. Schmetterberg triumphs more by her personality than by rules of science. Dr. Goutheil tries to make sense of her method of including family members in treatment, and he describes this as establishing a multiple transference to fit the polymorphous personality of the patients. I really love the term polymorphous personality because it eloquently captures what we now describe as a stably unstable person. There are a few things I want to highlight here. The first is how these analysts struggled to fit these patients into their tidy analytic formulations, and so they really all admit that traditional approaches are just not effective. Another thing to notice is that while Doctors Whittles and Goutheil are being very generous in their praise to Dr. Schmetterberg, there's also a little jab in there. So let me paraphrase it. She does art, but we do science. What psychoanalysts considered science, especially back then, is not what most modern scientists would recognize as science. They had a model, and it was formalized first by Freud and then expanded on by his successors. And this model was applied, well, more or less arbitrarily by whoever wielded it. But because it was a systematic process, they called it science. But psychoanalysis really did very little to test their hypotheses. The long-term listeners of this podcast might recognize that I have a tendency to criticize that psychoanalytic approach and its descendants. I do this because for so long in psychiatry's history in the US, they really held a stranglehold over progress and avoided any direct scientific testing of their methods. I also feel like this tradition can never actually embrace a scientific approach because that would really require that they abandon like the rigidity of their models. Recently, I was in a course with a psychoanalyst who gave us a review article and claimed that this review article proved that psychodynamic therapy was far more effective than any of the newer methods, including cognitive behavioral therapy and psychopharmacology. The review article was actually a review of other reviews and meta-analyses. So I decided to look into some of the studies that had been included in these analyses, especially those that were claiming really high effect sizes, like an effect size of 1.8 for psychodynamic psychotherapy. Now, for those of you who don't know, 1.8 is a relatively huge effect size in psychiatry. Most treatments hope to get something between 0.5 and 1.0. So when I explored the studies included in the meta-analyses with the most impressive results, it became immediately clear to me that the patients included in those calculations were only those who had actually completed 50 sessions of therapy. Now, I was surprised, but also not, that an analysis that did not include patients who did not do well with the therapy even made it into publication. Just to be explicitly clear here, if you only include patients who complete a full course of a therapy, and that course is a very long one, then you are in essence just excluding any failures from your data. So this is a classical way to stack the data in favor of a large statistically significant effect size, or what is called now p-hacking. We only included patients who did well. This is called pseudoscience. When your methods have all the trappings of science, they look like science, but instead, when you get down to it, they more resemble marketing campaigns than actual science. It's easy to win when you refuse to count your failures as real. Now, I need to be fair here and point out that psychoanalysts are not the only people in the world that overstate their claims. So more recently, what is considered to be scientific is often more technological in nature. In our modern times, we think of science and technology as being somewhat equivalent. For example, a 2023 study in Progress in Neuropharmacology and Biological Psychiatry reports to have discovered transdiagnostic inflammatory and oxidative biomarkers that have, quote, predictive capacity of self-injurious behaviors. They identified chemical markers on various assays that were statistically associated with conditions that they were measuring, like self-injury. At the end of the study, though, they asserted that their data is, quote, strong and will, quote, lay the groundwork for developing screening tests for these biomarker components to rapidly detect biological risk factors for specific impulse control disorders and future self-injurious behaviors, unquote. Similar to the claims of the psychoanalysts, these sorts of statements by researchers who are claiming to practice biological psychiatry can also be interpreted more as like marketing than as a dispassionate report of preliminary results. I mean, this study included only 35 patients with a diagnosis of borderline personality disorder and 23 controls. I really suspect that their confidence in their results vastly outweighs the power of their study to make the kinds of claims that they just made. Now, there are many claims like this in the literature, and the more I read them, the more I assign a very low probability that they will actually be useful. Now, let me get back to borderline personality disorder in particular. So, the desire to explain borderline personality disorder, like in whole or at least in part, by whatever is the most available or novel test at the time, it's really a common thread in the literature. And as far as I know, none of these tests have been fully satisfactory. Some have noted that borderline personality disorder might not be a thing in and of itself, but represent some more kind of generalizable pathological syndrome, a kind of general personality functioning failure, or more broadly, a generalized psychopathology. There are entities called the general personality pathological factors, or general factors of personality disorders, and something else called the P factor. Now, the P factor is the more generalized psychopathology as a whole, and the other two focus on personality functioning in particular. According to a 2018 review of these factors, they've been described in what appear to be like three separate and independent literatures that don't really cross over, even though they seem to be talking about almost the same thing. One of these factors, let's call it the GFP, was derived to a large extent from that 5-factor model that I discussed in the previous episode, so go back there if you want to hear about that a little bit. The other factor, I can call the GPD, is reportedly very similar to criterion A of the alternative personality disorder formulations that are proposed in the DSM-5, so also see my last episode for a discussion of this. Now, what both of these factors appear to capture is severe dysfunction in both intrapersonal and interpersonal relationships. That is, patients with borderline personality disorder have especially difficult time displaying a coherent and stable identity that they can also see as a distinct identity from other people. So they have a hard time seeing other people as having an identity that's distinct from their own. Instead, their own formulation of their own identity and their own perceptions and those of other people often appears to just arise de novo, and it's kind of reformulated in reaction to whatever affective state someone with borderline personality disorder finds themselves in. Now, that is to say that their own personality can be highly variable, and the way they view other people can be highly variable. Now, that P factor that I mentioned has been proposed as representing some kind of a general tendency toward any kind of highly prevalent psychopathology, including like affective disorders, psychotic disorders, anxiety disorders, and obsessive disorders, etc. What I mean is that the P factor is thought to provide an explanation of some common factor that results in all of these. Now, the core features of borderline personality disorder can be seen as representing many of features of those other disorders, affective disorders, even psychotic disorders. Another proposal is that the concepts like the P factor are really just a statistical phenomenon related to the way we describe or the way we interrogate psychopathology, using, for example, like opposing features like agreeableness versus antagonism. Although there's likely a broad continuum between agreeableness and antagonism, given just those binary options, people will tend to fall out more toward the extremes. They don't really consider the middle very much. One quote that I like very much is from a paper by Caspi and colleagues in 2014. They note that it is at least possible that the p factor is, quote, merely a statistical reductio ad absurdum, unquote. So aside from sounding like a spell in Harry Potter, I think what this means is that the p factor, and I'm also going to generalize this to those other two factors I talked about, might just be statistical phenomena and not really particularly meaningful. It could also mean that all of these factors are merely measuring the consequences of psychopathology and not really their etiology or their causes. They describe psychopathology instead of explaining it. And the consequences of various pathological factors can be very similar. So I want to just give a shout out to this paper by Oltzman et al. You can see it in my references, and you can find the references in the transcript at scydactic.buzzsprout.com if you want to explore this in more detail. But to understand borderline personality disorder, especially the more severe aspects of it, it's often more meaningful to actually describe a patient. Again, I'm going to rewind to 1956 and quote Dr. G. Hill in the Psychoanalytic Review. I like these older reports because the language is generally more colorful and descriptive. This kind of stuff probably wouldn't get published today. So in a case report, Dr. Hill introduces a patient as, quote, a narcissistic, affect-hungry, infantile young woman of 26. And he goes on to describe her recent history as, quote, 3 suicide attempts followed by drunken extramarital sexual episodes, unquote. And then Dr. Hill asks the question, quote, what type of object relationship does this patient make? Then he describes a long and torturous history of a sexually and emotionally abusive mother who also supplied the patient with excessive amounts of alcohol from a very young age. Now, stick with me here for a much longer quote that I think helps to capture many of the facets that are included in modern formulations of borderline personality disorder diagnoses. Quote, Jenny would fall into the group of borderline states. Both in psychological testing and in clinical appraisals, there was defective reality testing. For example, immediately on waking from an afternoon dream of purchasing a dress, she went out and did so without regard to her budget or her responsibilities to her children or her apartment. Such impulsive behavior stemmed from strong wishful thinking, illustrating her overpowering narcissistic orientation. There were eruptions of primary process in her assaultive outbursts. Further evidence of distorted thinking is depicted on an occasion when she described how her 3-year-old daughter had persuaded her to expose her genitals and then proceed to masturbate the patient. Questioning reduced this incident to one in which her daughter had actually only wanted to look under Jenny's dress. But this was not falsification. Rather, it was a lack of individuation between herself and her daughter, another peril of her narcissism. A constant problem was her feeling of emptiness, which she equated with being depressed. It was an instinct-driven affect hunger, compelling her to seek excitement in situations that brushed aside any resistance offered by the impulse barriers of her ego. Such forays into sexual aggrandizement and into alcoholic and narcotic channels showed the critical decompensation of her ego and its syntonicity with her impulses. This is the situation at its worst, spanned, however, by periods of calm etiquette, charm, and intelligence. Unquote. In Dr. Hill's description, you might see how borderline personality can be characterized as just generalized personality dysfunction, or even an example of just generalized psychopathology. But let's take a look at how this description, back in the 1950s, lines up with current DSM criteria. The DSM describes the primary condition of borderline personality as a pervasive pattern of instability of interpersonal relationships, of self-image and affect, as well as marked impulsivity. It then lists 8 criteria, 5 of which are required for a diagnosis. These criteria do not appear to me to be really independent of each other, but you just need 5 of the 8. With regard to interpersonal relationships, patients with borderline personality disorder may display, quote, frantic efforts to avoid real or imagined abandonment, or, quote, a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation, unquote. Now, these traits often result in what is described as, quote, inappropriate, intense anger, or difficulty controlling anger, for example, frequent displays of temper, recurrent physical fights, unquote. With regard to the description of Jenny, Dr. Hill noted many assaultive outbursts in her past and described a, quote, lack of individuation between herself and her daughter. Now, this lack of individuation means that Jenny had difficulty knowing the boundaries between who she is, who Jenny is, and what Jenny wants, and the identities and desires of her daughter. Now, this lack of a clear self-identity spills over into interpersonal relationships. A related feature of borderline personality disorder is the tendency to split, which the DSM calls extremes of idealization and devaluation. So in relationships, splitting may have to do with this transient feeling that someone else really fills up that empty space inside. But then invariably, that other person turns out to be just, well, an ordinary human. And this fact that their lover or their friend or their therapist is just a human is experienced in a borderline mind as a betrayal. Whatever prevents Jenny from experiencing a coherent sense of self that's distinct from others is also likely related to her tendency toward dissociation. So these are symptoms such as depersonalization or derealization, where she either loses a sense of kind of the boundary between herself and her environment or experiences the world as if she's in some kind of dream state. Jenny's sense of self and of companionship is really fragile, and she's able to lose her grip on them kind of with the slightest stress. For those of us who've never experienced something like this, it can be really difficult to conceptualize or relate to. Having such an undeveloped sense of self combined with instability of interpersonal interactions and apparently primitive skills at controlling emotions or impulses. Jenny also describes chronic feelings of emptiness that she believes are signs of depression. She may go on unplanned shopping sprees, sexual escapades, substance use binges, etc. Her behavioral instability is also complemented by affect instability, where her feelings in whatever moment appear independent of any wider perspective, and often the result is assault, self-harm, or suicide attempts. She might then experience intermittent periods of relative calm and composure. One might see how borderline personality disorder got its name. The patient appears, like many psychotic patients, to have disorganized thoughts and behaviors. They can also report transient perceptual disturbances, especially during dissociative episodes. They may be gripped by a sudden paranoia and lash out at the world around them, under the assumption that they're being harmed or abused or used, and that is often the case. So, in addition to disorganized thoughts and behaviors, their mood appears equally disorganized. Back when psychiatrists split symptoms into the categories of neuroses and psychoses, borderline patients appeared to suffer alternately or at the same time from both. Now that I've discussed a little of the historical ways in which borderline personality disorder has been described and how those descriptions line up with the current diagnostic criteria, I want to discuss some of the research into borderline personality disorder that attempts to distinguish it from disorders with similar symptoms. One similar disorder that appears in the ICD-11 but not in the DSM is complex PTSD, which is also similar to a diagnostic entity called developmental trauma disorder. The main idea here is that borderline personality disorder results from disrupted personality development, and that is the result of abuse, neglect, trauma, or instability during early development. I have colleagues who agree that borderline personality disorder should be moved to the trauma-related disorders in the DSM. And given the current imperfections of the DSM as it is, I am sympathetic to this view. It's not a perfect compromise, but maybe better than what we have now. A review titled Complex PTSD and Borderline Personality Disorder in 2021 concluded that PTSD and complex PTSD and borderline personality disorder all have distinct features, but they also are highly comorbid, and they might represent some kind of continuum or spectrum disorder. So while trauma is a prerequisite for PTSD and complex PTSD, it's not for borderline personality disorder, and not everyone with borderline personality disorder reports a childhood or adolescent history of trauma, neglect, or instability. However, it is extremely common among patients with borderline personality disorder. Here's a quote from a review I just mentioned. Adults diagnosed with borderline personality disorder have been shown to be 3 times more likely than adults with other psychiatric or personality disorders to have experienced childhood maltreatment, and 13 times more likely than adults with no psychopathology. Emotional abuse and neglect were particularly prevalent, with borderline personality disorder associated with more than 30 times increased likelihood of the former and more than 20 times increased likelihood of the latter as compared to non-clinical adult samples. Physical abuse and neglect and sexual abuse also were more prevalent in borderline personality disorder cohorts than non-clinical controls, with an approximately 7 times increased likelihood among borderline personality disorder diagnosed persons, unquote. One might conclude from this that borderline personality disorder is caused by environmental factors such as trauma. However, a very large prospective population study in Sweden that analyzed data from 1.8 million people estimated that the heritability, the genetic contribution to borderline personality disorder, is about 46%, meaning that the genetic components account for about half of the variability in whether or not someone is diagnosed with borderline personality disorder or not. So this study looked at borderline personality as a binary variable and not as a continuously varying traits of borderline personality. It also reported that variation that could be attributed to environmental factors determined by the family itself, that includes things like the family's socioeconomic status or their religion, were insignificant both in magnitude and also statistically in their best fit model. Of those diagnosed with borderline personality disorder, 85% were women, and the authors caution the reader against generalizing these results to men because they didn't have the statistical power to do that. It could also be that men with traits of borderline personality disorder are actually more likely to get diagnosed with something like antisocial personality disorder instead, because a lot of the traits overlap and men are seen as more threatening. And when they act impulsively or out of anger, this might be characterized as a violation of the rights of others instead of as self-harm or, quote, hysterical behaviors. We just don't know for sure. What appears to be the case is that there is a strong genetic by environmental interaction that results in the features of borderline personality disorder. In the Swedish study, I could not find a description of how they assessed for trauma exposure explicitly. They did report that they would consider this to be an individual risk factor and not a familial one. But it remains unclear what the correlation is there and what the correlation between genes and environmental exposure actually is. What I mean by this is whether or not genetic components might increase the rate of behaviors that also result in trauma or contribute to unstable environments. And these kind of feed back on themselves to greatly increase the risk of borderline personality disorder or worsening of borderline personality disorder. We just don't have good data for that. We also don't know what the particular genetic components are that contribute to a diagnosis of borderline personality disorder and exactly how these are shared with other disorders, like disorders of affect or other impulse control disorders. There are papers that identify some candidate genes that are common in multiple diagnoses, but I don't really have time to get into that. Borderline personality disorder that results from, or is instigated by, or associated with a trauma history may be a distinct cluster within the possible borderline personality disorder symptom combinations. So according to a 2017 paper that attempted to find clusters in borderline personality disorder, they noted that there are really 256 possible symptom combinations that can result in that diagnosis, and so maybe there are distinct clusters. Their analysis resulted in a proposed 3 separate clusters. One of these clusters, which they called the extrovert externalizing cluster, was composed of patients with symptoms that are shared by other cluster B diagnoses, including histrionic, narcissistic, and antisocial personalities. Another cluster, which was less common than the other two, were patients with a large degree of schizotypal or paranoid features. But the most common cluster of all was composed of what they considered to be the core symptoms of borderline personality. And this cluster had the most severe features, including identity disturbances, whereas identity disturbances were less common in some of the other clusters. Statistically, it makes sense that not everyone who is diagnosed with borderline personality will have a trauma history. Most likely, the group of patients with a borderline personality diagnosis have variable pathologies and different etiologies for their particular traits. However, it is clear that developmental trauma puts people at a much, much higher risk of developing the core features of borderline personality. Now, I'm getting near the time limit that I have set for myself for these ramblings. But before I end, I want to highlight a bit about the treatment of borderline personality disorder. The early psychoanalysts were right when they supposed that these patients need therapy, but that their kind of therapy was not really well suited for the job. The frequency of crises, or what Dr. Schmidberg described as something always happens, in the lives of borderline personality disorder patients can make it seem really difficult to make any progress in therapeutic regimens. Life-threatening behaviors are also very common, and of course, they take priority over everything else. But a large part of the therapy for borderline personality disorder includes reducing the frequency or the intensity of crises like these. It can seem like a daunting task to evaluate for suicidality so frequently in someone who has chronic relapsing and remitting suicidal behaviors. And these patients may suffer from the fact that people in their lives suddenly stop taking these behaviors seriously. A full assessment for intent and means should always be conducted and explored. And ways to address whatever triggered this episode are very important. Now, although there's no longer the common practice, and it's not the standard of care for most suicidal patients to make a no suicide contract, that's a contract where a patient agrees not to commit suicide and can sign a paper. It actually may be necessary to have borderline personality disorder patients make commitments to not engage in self-harming or suicidal behaviors while in treatment as a means to keep the treatment going. Now, this is not a contract you do when a patient is acutely suicidal. This is something you do near the beginning of therapy to explain to the patient how important it is for them to maintain a certain level of stability so that the therapy can progress. And also, these contracts should never be seen as like risk reduction tools or as like a legal release form that protects the therapist from liability if the patient does do something. Therapists are still responsible for doing thorough safety evaluations. Alternative ways to deal with stress besides self-harm or suicidal acts or suicidal threats in a moment have to be provided. And in some cases, I've heard of therapists even giving a patient their personal phone number as a way to provide them with an outlet to do something besides self-harm or besides suicidal behaviors. I'm not recommending to therapists out there that you do this, and I'm not actually making any recommendations on what you should or should not do other than don't do suicide contracts with most patients. I'm really just reporting that I've seen this done before. Now, psychotherapy is the only thing shown to be effective for the symptoms of borderline personality disorder. Although nearly all patients being treated for borderline personalities will find themselves on one or more psychotropics. Many will be on multiple medications, including antidepressants, mood stabilizers, sedative hypnotics, anxiolytics, antipsychotics. Now, about 1 in 5 patients with borderline personalities who are in treatment will be on 4 or more medications. Current recommendations stress avoiding medications unless there is a clear comorbid condition. And even then, psychotherapy focused on the particular symptoms of that condition may be the best place to start. Now, for medical students taking their qualification exams, dialectical behavioral therapy, or DBT, is generally the right answer. If it's asking, what should you do for a patient who has borderline personality disorder? But other forms of therapy can be used and are used, and they have similar results. So these include mentalization-based therapy, transference-focused psychotherapy, and schema therapy. Finding therapists that specialize in these treatments can be really difficult, and many, at least in my region, I think most or all that I've come across, will not accept insurance. Those that do are actually working on inpatient settings, really where limited gains can be seen because the patients aren't dealing with these issues in real time or over long periods of time. So that characterization by Dr. Whittles and Guthiel in 1947 of the treatments for borderline being kind of more of an art than a science doesn't really ring true today. Though both DBT and schema therapy are rather eclectic, they're not anything approaching like the seat of the pants therapy that Dr. Schmedberg described herself doing. However, the instability of borderline personalities require kind of a level of improvisation and adaptability on the part of the therapist, and that itself can be described as an art form. Although borderline personalities are often severely disabling and difficult to treat, many patients will remit with therapy, or at least make substantial improvements in their life. Time itself often changes the character of borderline personality disorder, with depressive and kind of avoidant symptoms becoming more dominant as patients age, and those impulsive, risky behaviors and self-harm are more common in younger patients. I've not yet addressed the stigma that results from both a diagnosis of borderline personality and from reactions to some of its core characteristics, such as self-harm and suicidality, idealization followed by devaluation, and impulsive behaviors. Also, borderline personality patients through time often become more and more intense medical resource utilizers, and they have many vague and difficult to treat somatic complaints, along with higher rates of chronic medical conditions. So as they age, these patients often become increasingly isolated. Part of a psychiatrist's job, especially in consult and liaison roles, is to educate other providers about the severe disability associated with borderline personality disorder and encourage providers in the hospital to not take personally the actions, words, or accusations that these patients may make. Now, it can be difficult to insist on healthy boundaries while at the same time not just avoiding interactions with borderline patients, while at the same time continuing to provide them with excellent care. Part of this balance includes encouraging empathy in both directions, from the patient to providers, but also from the providers to the patient. Thanks for hanging with me today. For a more structured and complete review of borderline personality disorder, I suggest you go to PubMed and type in borderline personality disorder, a comprehensive review of diagnosis and clinical presentation, etiology, treatment, and current controversies, or some version of that. There's an article that's officially dated February of 2024. That is one of the best that I've found so far. I would also appreciate any feedback you might have for me. I have a form you can complete at Psydactic.com, and I also have a YouTube channel. You can search for me at Psydactic and leave a comment on the particular episode if you'd like. Next week, I'm excited to bring you an interview with Dr. Jan Lindefeld, and we're going to have a conversation about HIV psychiatry. So tell your friends and your mom to tune in. Thanks again for listening. I am Dr. O, and this has been an episode of Psydactic.